Hi, I'm Beth Paget. I'm a surgical house officer working in the West Midlands and a recent graduate of Warwick University. Today I'm going to be talking to you about pancreatitis, specifically acute pancreatitis. So let's start with a case. Mr. X is a 55-year-old man who presents with acute onset abdominal epigastric pain, which radiates to the back and is associated with nausea and vomiting. On examination, he is tender in the epigastric region. He's hypotensive, tachycardic and tachypneic. We'll come back to the case. But first, let's talk about the pathophysiology of pancreatitis. Pancreatitis occurs as a result of autodigestion of the pancreas by pancreatic enzymes. What this means is that instead of going into the gut and helping digest food, the enzymes get stuck and instead they digest the pancreatic tissues. This results in edema, which results in fluid shifts. And that can be from intracellular to extracellular or from intravascular to extravascular. What this means is that the circulating fluid volume is lower and thus is the BP. In severe disease, there may be erosion to the vessels, which results in hemorrhagic pancreatitis, so bleeding. Let's talk about the causes of pancreatitis. Now, assuming that you're all final year students, you will have met the following mnemonic. We can make the causes spell I get smashed, but really the first three are the most important. So we'll go through them. I is idiopathic, G is gallstones, E is ethanol or alcohol, T is trauma, S is steroids, M is mumps or malignancy, A is autoimmune, S is scorpion stings, although this is very rare, H is hypercalcemia or hyperlipidemia, E is ERCP, and D is drugs, including thiazide diuretics, thiazide-like diuretics, and azathioprine. So how do we diagnose pancreatitis? There are three common features. You need two of them to diagnose pancreatitis. The first is a raised amylase or lipase, and that's more than 3 times the upper limit of normal. The second is a compatible history, commonly epigastric pain radiating to the back. And the third is compatible imaging. This can be ultrasound, a CT abdo-pelvis, or an MRCP, which is the gold standard. So how does pancreatitis present? Most commonly, it's acute onset epigastric pain, which radiates to the back. It is severe and it's associated with nausea and vomiting. Depending on the severity, there may be SIRS or a systemic inflammatory response syndrome. Depending on the cause, there may be jaundice, there may be bruising in the flanks or periumbilical, and there may be pleural effusions and ascites. So how do we investigate pancreatitis? Let's start with the blood tests. First thing we look at is a full blood count to look at the hemoglobin. Hemoglobin may be raised in dehydration or reduced if there's a hemorrhagic component. The white cells may be raised again if there's an inflammatory or infective component. The C-reactive protein, or CRP, will be raised. Glucose may be high. LFTs may be raised or normal, depending on the origin. If there are gallstones, the alkaline phosphatase, ALT, and bilirubin may be raised. If there is an alcoholic component, the gamma-GT will be raised. We check amylase or lipase, depending on the trust, which will be up to 3 times the upper limit of normal. A blood gas, this can be arterial or venous, will indicate the amount of circulating oxygen in the blood. It may also indicate a lactic acidosis, which can be a feature of severe pancreatitis. Calcium may be decreased and LDH may be raised. So what do we see on imaging? On a chest X-ray, there may be pleural effusions, and that's due to the fluid shift that we talked about before. Abdominal X-ray may show a dilated loop of small bowel near the pancreas, and this is called a sentinel loop. An ultrasound may show peripancreatic inflammation and edema. It may show gallstones or CBD stones, and it may also show cholecystitis or a dilated, inflamed gallbladder. But MRCP is the gold standard imaging, and this will show in much more detail everything else that we talked about. So how do we risk stratify pancreatitis? We separate cases into mild and severe. And to do this, we use the Glasgow IMRI score. A score of 3 or more indicates severe pancreatitis and needs more senior involvement. Now, helpfully, we can make this spell pancreatitis. No, we can't. We can make it spell pancreas. So how do we risk stratify pancreatitis? And now I can't even say pancreatitis. Bah, okay. So how do we risk stratify pancreatitis? We can divide cases into mild or severe. We do this by using the Glasgow IMRI score. A score of 3 or more indicates severe pancreatitis and need for involvement of ITU support. We can make the spell pancreas. So P is PaO2 of less than 8, age is more than 55, N stands for neutrophilia, we've got calcium of less than 2, renal impairment, enzymes including a raised LDH and AST, albumin of less than 32, and sugars of more than 10. And again, a score of 3 or more indicates a need for more senior support. So how do we manage pancreatitis? Now, mostly it's supportive care. This means aggressive fluid rehydration initially, and this is to prevent kidney injury and to prevent hypovolemia and hypotension. We also need careful fluid monitoring. If we're pouring lots of fluid into somebody, we need to make sure it's coming out as well, so the patient may require a catheter. We need analgesia, so painkillers, and antiemetics. Commonly this is cyclizine or ondansetron. If there are signs of infection, such as a fever or a raised white cell count, there may be antibiotics required. Each trust will have their own guidelines on this. If there is severe nausea, they may require an NG tube, and depending on how severe, they may need ITU involvement. So what are the complications of pancreatitis? Up to 20% of severe cases may die. And this can be from a number of reasons. There's multi-organ failure in severe pancreatitis. This may present as ARDS, so acute respiratory distress syndrome, AKI, which is acute kidney injury, or paralytic ileus, or disseminated intravascular coagulation. You can have chronic pancreatitis and chronic pancreatic insufficiency in the long term, and also pancreatic necrosis, infection, and abscesses. So that was a whistle-stop tour of pancreatitis, and I think it's everything that a finals level student needs to know.